for that presentation. She's a very versatile person. She has multiple interests, Dr. Andrea. She's a dancer. And now I request Dr. Naina for her second presentation on internuclear ophthalmoplegia and other supranuclear abnormalities.
So we are going to the clinical scenarios here. I've discussed about saccades and pursuits in a very short. So just look at this patient who had come to our hospital with this movement abnormality. So her pursuits are being examined. So we'll come to this picture with a magnified view. So we'll be talking about the MLF. So the MLF is a myelinated nerve bundle which connects the third, fourth, and the sixth nuclei in the brainstem. And the MLF lesions produce the INO and the 1.5 syndromes and the related syndromes. So this is a very typical and very familiar diagram we have always learned in ophthalmology. And you can see that the left, the parapontine reticular formation is the brainstem center, which sends impulses to the abducens nucleus. And from the abducens, it goes to the MLF, to the oculomotor, and the oculomotor which will supply the left medial rectus. And that will give you the right gaze. So if you have the INO-like symptoms, INO lesion, the patient presents with a horizontal diplopia that is not in the primary gaze, it will be more in the opposite side of the lesion, and there is a difficulty in tracking high-speed objects, dizziness in the lateral gaze, and headaches because of the brainstem involvement. So if you want to diagnose INO, you need a good extraocular movement assessment, and you will see that there is an ipsilateral adduction deficit with a contralateral abduction deficit. In the picture, you can see the primary gaze, the patient looks fine, but on the right gaze, there is normal adduction and abduction, whereas on the left side, left gaze, you see the adduction is -2 to -3, and there is also going to be a decreased horizontal velocity. So coming to this patient, which I showed earlier, so in this patient, you can see on the right gaze, the right eye abduction nystagmus, and if you can see, there is a left eye nystagmus, and there is a convergence deficit on the right eye too. So if you just go back, I'll show you again. So even in the left side, you see the adduction is -1, abduction nystagmus on the right, whereas on the left gaze, there is adduction -1 with an abduction nystagmus. So this is a bilateral INO. So usually INOs maybe you can get bilateral lesions because the MLF is in the midline, and it is not surprising that you always get an unilateral. So there's another, for the postgraduate interest, there's the INO plus lesions, that is the hypertrophic skew deviation the same side with abnormal OKN, and you get a vertical gaze. As I said, INO is a horizontal gaze deficit, but in INO plus you get a vertical gaze abnormality too. Now pseudo-INO you get in myasthenia and also in Guillain-Barré syndrome. And convergence may be normal or absent because in anterior INO, which there is a lesion in the midbrain, so there's going to be an absence of the convergence, whereas in posterior INO it is said to be in the pons, so the convergence is going to be normal. Bilateral INO, Webino, you have a primary position exotropia, and you have bilateral adduction deficit with bilateral abduction nystagmus and a vertical gaze evoke nystagmus. There is also Webino and monoocular INO with primary position exotropia. Coming to 1.5 syndrome, that is where the MLF and the PPRF are involved. So in this picture, you can see that on the right gaze, you have an adduction -1, the left eye abduction is normal, whereas in the primary position is normal. But on the left gaze, you have the adduction also a deficit, the abduction is deficit. So the only movement which is there is a abduction of the eye, and this is the left 1.5 syndrome. So there is no horizontal movement in the ipsilateral eye, only movement you get is a abduction in the contralateral. So etiology of INO and 1.5 and the syndromes is demyelination in a young patient, ischemia in older patients, infections, inflammatory, and so on. I'm coming to paranoids. Paranoids is a condition where you get a vertical gaze palsy. So I was talking about horizontal. So just look at this video, and you'll see a very typical movement in this patient who was referred from the neurosurgical department. Is a 40-year-old patient who had a very interesting picture. This is a convergent retraction nystagmus, and he had an vertical gaze palsy. So I was always asking him to look up, but he was trying, but this is the picture you get when he's trying to look up. So it is a very typical convergent retraction nystagmus, and this patient was operated for a melanoma. So the lesions for the etiology for the paranoids is the brainstem hemorrhage, melanoma, hydrocephalus, AV malformations, and head trauma. Then one more condition, progressive supranuclear palsy, is also a patient we had, but unfortunately I don't have a video. It is diagnosed to be like a Parkinsonism. It's a differential diagnosis for Parkinsonism. Patient has Parkinsonism-like features, poor response to levodopa, because levodopa is given for Parkinsonism. These type of patients don't respond, and they have a vertical saccade and problem. Usually they present with downward gaze palsy, up gaze palsy later. And they have this very square wave jerks. I hope Dr. Rashmin Gandhi sir would show those pictures, because I didn't get a video for this patient. And they have convergent insufficiency. So saccades and pursuits have to be assessed in every patient with neurological or neuroophthalmic signs. And abnormal ocular movements may not be confusing and challenging if a thorough extraocular movement assessment is done. Thank you, ma'am. I would really like to thank Elizabeth madam for putting me in the hot spot with this abnormal extraocular movements, but I have definitely read, and I hope to get better.
Thank you, madam, for that excellent presentation. Next, I'd like to invite Dr. Elizabeth Joseph, madam. She needs no introduction, a passionate pediatric ophthalmologist, and she can be addressed as a superwoman in strabismus surgery in India today. She is a HOD and heads the pediatric ophthalmology department at Little Flower Hospital, Angamali. She has innumerable awards, papers, and she's an excellent teacher and a mentor, and she does simple as well as complex strabismus surgery in a flash. She still keeps her passion for her subject by having talks on all these 3 days in Drishti 2023, Thrissur. And over to you, dear madam, for your talk.
Thank you, Dr. Arya, for that very kind and wonderful words. Thanks. Now, I'll be talking on nystagmus surgery, when and how. See, nystagmus, all of us know, is just a repetitive to and fro involuntary eye movements initiated by slow